Good morning, good afternoon, good evening from wherever you are. I'm so glad that we can get together again. It's been a number of years since I've been able to get out on the road. So you all that know anything about me know that pediatrics is my passion, as it is for Carol. And we work very closely together. So because she does all the grunt work, like this beautiful PowerPoint that you're going to be seeing, I wanted her to be ombudsman with me. So that's the way we're managing right now. If we can go on to the next slide, Carol.
Okay.
So just as we begin to look at pediatrics in our classes when we used to be together, you see in even the virtual study guide this bit of wisdom from Dr. Upledger. And that is that a person's a person, no matter how small. It's important for us to treat them that way. So as Dr. John said, the inner wisdom of a child is every bit as intelligent as that of an adult. And I would go on to say the oldest adult you could think of. So we need to honor that whenever we're working with children. And even though this is just an introduction to the virtual class, I'd like you all to remember that. And I hope that you will do the virtual PEDS 1 class, because this is a large piece of it. It's important that we remember that when we're working with children, we don't have to be childish, but we do have to think in a childlike way to understand how they're thinking. So that's the attitude that we approach working with children. It's like that. It's like, what can we discover? What can they teach us? What can they show us? So this is, to me, the most important piece. When you're working with pediatrics, this is the most important thing to do. This will give you access to be able to get your hands on and do what you know how to do with your hands. It's about blending, it's about melding, it's about your therapeutic presence. And I know you've all heard that before, but years ago when I developed the class, not many people were talking about that. It's paramount in this work. So I'd like, if we could, to take just a quick moment to go inside, feel your feet on the floor, feel your seat in the chair. Take some deep breaths in through your nose, out through your mouth. Let out a sigh if you need to. And fill yourself in whatever way you do it. Fill yourself with all the light, all of the energy, all of the love that's available to you, because that's what you're going to share with the children. And now that we're in that space and we're filled as much as we can be, imagine connecting to each other around the world. And notice right now how that feels. Thank you all. That's important. This is what you need to do before you go in to work with a child and the family. And it's what you have to continue to do as you work. So we might get focused on certain areas, but never forget that you are a conduit. Dr. Upledger used that terminology. You're a conduit. It can all flow through, and it's very important. Moving on, next slide. So, second most important thing is understanding that safety is a primary physiological need for every one of us as human beings. So when we're working with children, what you get from this class is learning how to explore what does that child need from me? What does that parent need from us together? And in these times with COVID, I understand that you're shutting back down over there in Europe. Am I right about that, maybe? So it may be that you're not going to be able to see the children directly. So it's important that we stay connected to the children that are already our clients, to those parents, so that we can support them. For example, they could send a video of what's happening with their child, or they could send you a text or an email and let you know what's come up. And using the tools that you will learn from the PEDS 1 virtual class, you'll be able to support them even though you may not be able to get your hands directly on them. Okay? So, moving on. This is what it looks like to palpate safety. And yes, that is Dr. John up in that left-hand picture. I think that child is literally palpating safety from him. But it was his way of showing them where he was going to put his hands so that they didn't anticipate that it was going to hurt. Another thing that we go over in PEDS 1 is the issue, very important, about focused attention and non-focused attention. So you'll be doing some practices, exercises about that. But if you look at the right-hand lower picture, you know exactly what I'm talking about. Yes, mama's holding the baby, but that's not where her focus is, right? And baby is letting you know that. Look at baby's face and eyes. Baby's on track with something over there and mom doesn't even know it. So we'll discuss that. We'll practice it. I think you'll find that it's much more powerful than you might ever imagine. And I know that most of us who've been doing this work for a while, or maybe some of you who haven't, say you've got, well, right now we've had Tropical Storm Eta around here. So we've had lots of rain. So maybe I'm focused on, I've got my hands on a child, but I'm thinking, I wonder how I'm going to get that leak fixed in the roof. You're going to learn in the class how to manage your own thoughts so that you can stay very, very focused and very present to be able to help them. Next slide, Carol. So in this class, another piece that's extremely important is the review of what you learned in CS2 about the reticular activating system. Sometimes in your anatomy books, you'll see it as the reticular formation. Some people have, it's kind of a misnomer to call it the reticular alarm system, because it's basically a filter. But you'll learn all about it. You'll see diagrams of it. You'll learn to get it in your hands. You'll learn to palpate it. Because if you're working with a child on the table or a baby over 3 months, if they're on sympathetic, then what's likely going to happen is all of their senses are going to be heightened and they're going to be very stressed, right? What do we know that craniosacral therapy does almost immediately when we begin to work? It shifts the autonomic nervous system so that we have a much better balance between sympathetic and parasympathetic. And yes, there is social as well. And it has pieces of both. All right, we'll talk more about that in the class. But what I want to get the point across here is that we'll be going into this with great detail because it's very important for you working with children to stay tuned to where is their autonomic nervous system in any particular moment in time as you're working together. Okay. The quote at the bottom I love from Dr. John. I use it all the time, as Carol knows, ad nauseum. Shortest distance between 2 points is an intention. So again, just like with the reticular activating system, just like when you're doing your focused attention and intention and not letting your mind wander, you can use that principle in order to elicit a lot of that feeling of safety. It's okay. Yes, things are changing, but it's okay. Next slide. So there's one of the pictures that's in the study guide. And if you read in the lower right-hand corner, the point to understand about tuning into the reticular activating system or the reticular formation is that in any given moment, whatever it's doing, it has influence on every other system in the body. So think about, like Nikki Campbell Kennard talks about the second brain and our gut reaction. That's part of it. It's every system, heart rate, respiratory rate, digestion, all of it. It's extremely important. Now that pulls us back to understanding why it's so important that we stay in that place of balance, of grounding, filling, and remember that still point was one of the very first things that you learned how to do in CranioSacral Level 1. So that's a key piece to be able to initiate help. Next slide, Carol. This is a quote from Judith Bluestone. Some of you may be familiar with her. She developed a system of treatment called the handle technique, holistic approach to neurodevelopmental learning efficiency. Her quote is so true. Stress systems don't strengthen. And one of my passions for revamping PEDS 1 back in 2005 was that I saw people with babies in particular in somatoemotional release. And what I noticed was that they weren't taking into account this statement. Stress systems don't strengthen. So most of you probably already know that to treat babies and children is a very fine-tuned skill. It's more difficult than adults. It truly is. Becomes an art and a science because we have to monitor, again, in every single moment, what's happening in the nervous system of that child and that baby, and know, it's like the old song, know when to hold them and know when to fold them. So even though you might be in a still point and the rhythm is off, if you're pushing too fast, too far, you're going to get the kind of reaction that you see from that little guy in the picture. So you learn in this class how to manage, how to juggle all this. It requires more skill than perhaps treating the average adult. So you learn all about that. That's the passion that Carol and I have to share with you. Very important. Next slide, Carol. So here are some specific ways that you will learn to utilize when you take the PEDS 1 virtual class. You'll learn these very specific examples of just right touch, and you'll learn what exactly that means. You'll learn that heavy pressure, being a container for that child or that baby, actually makes them feel safer. So it's about setting physical boundaries and about whether or not you can use a certain amount of intention with a certain amount of pressure simultaneously. You'll learn what some of the reassuring words are that we use with babies and children, and you'll learn the Hendricks model of communication. Some of you may be familiar with that if you know imago therapy, but that's all about listening to what the child or the baby is trying to tell you, listening to what the parents are trying to tell you, validating their experience without necessarily agreeing with them. For example, if the child is 3 years old and they want to get off the table, they want to get down, they want to go bye-bye, your job is to listen to that, to validate that. I understand. Oh, I see that you want to go bye-bye. I see that you want to go home. Doesn't mean you're going to let them. It just means that you're going to validate them and that you're going to empathize with them and you're going to help them because you're going to learn lots more things about working with children and babies. So you'll have the tools in your toolbox to be able to help them so that you get past that wanting to go bye-bye, all right? You'll also learn that sucking is a way of getting oral proprioception, so mouthing toys and things. You'll learn that familiar toys and objects, for those of you that may have already treated pediatrics, you may have learned that if you change your room at all, your treatment room, and a certain toy, that they always know is in a certain place, and that's going to be what their go-to. I want that. Those kinds of things are neurologically calming. So we offer suggestions to the parents of things like bring a familiar toy, bring the blankie or the soft fuzzy or the pacifier from home, because not only is it familiar, but it's got that child or that baby smell. And you'll learn about why, how that makes them calmer. You'll learn again how to build rapport with play, and you'll learn about mental rehearsal, which is going back to that slide in the beginning of the child with its hands on Dr. Upledger's head. That's what that child was doing. That's what Dr. Upledger was doing, was giving that child a mental rehearsal. This is what it's going to feel like. This is where I'm going to put my hands. You'll learn lots more about that. Next slide, Carol. So this is what you can expect when you're able to get your hands back on, blending and melding them and meeting them where they are. Some of you have heard that phrase before, but that's so, so important. And that ties in with the slide that we saw with the little guy whose eyes were like this. When we talked about stress systems don't strengthen, we're not going to try to make them fit into our world. We need to fit into theirs. We learn all kinds of things about understanding them and how they're thinking and those kinds of developmental progressions in this class, because your role is to be that neutral observer. And that's, Carol talks a great deal about that in the CCPB curriculum, that we need to be neutral when we start working on children and when we start working on babies, because you've got to be able to find what the issue is, where it is, and use observational skills so that you don't come in and go, oh, I see that energy, sis, I'm going to fix it, or I'm on it. It's coming in a very neutral kind of a way and allowing that child or that baby's body to show you what they need. So you'll learn lots more about how to do that. And again, you'll learn more about Hendricks' model. It's all about mirroring back what you think you're hearing or what you know you've heard, asking in whatever way if you've got it right, and then empathizing. With a nonverbal child or a baby, that validation sometimes is just saying, I understand you could feel that way. All right? So you'll learn lots of that. Remember that in this work, and when I say this work, I'm talking about working with children and working with babies that 3 months and older. It's always about letting the child direct you. Their body, their innate wisdom, going back to those first slides, is just as intelligent as the wisest and oldest of adults. So when a child gives a cue like what you see in this picture, listen. This work is very much about listening, isn't it? So let the child direct you. Next slide.
Oops.
So we're going to talk a lot, and you're going to have lots of practices. Not only, when you come together finally, but in this virtual class, listening and following versus doing. And that's what I was just alluding to in the previous slide. You're going to practice the role of the therapist as a neutral observer. And you get a better sense when you do that of what that child or that baby wants you to understand. Very important. You're going to use your observational skills in that role as a therapist, along with your palpation. So it's a constant monitoring of what are they doing now? Why are they doing that? Again, that's why it's so important that we go over things like the development, not only motor-wise, but psychologically as well. And we've already, again, this is review of what we've just said, therapeutic presence of neutral. Very important. So, not only will you learn motor development stages, you might ask, well, why is that so important? Because you might get a child in that family thinks they're developing just fine. But if you know where they should be, as a general rule, and you take, for example, language, and you take a look at where they actually are, you may be the first person to direct that family to an alert. Perhaps they need to be referred for speech, or perhaps it's a child with motor delays. Perhaps they're 12 months old and they're not crawling yet, and yet they seem to be developing just normally. Might want to refer them to physical therapy. It's important, unless you have studied child development, it's important to know where they should be, because it helps you understand neurologically what's going on with them and fine-tune your skills that way. So let's start talking now about what we cover in terms of modifications of treatment. And Carol has her skulls available, so I'd like to ask her to show that when we're done looking at this slide. But you can see on this slide how low that, and Carol has her skull up. See how low down can you point to that on your skull, Carol, the tempoparietal suture?
Okay. I have to see where it is.
So see how much lower that is than an adult? That makes a difference with your hand position, right? And remember that when you're working with a baby less than a year old, many of the bones have not fused. They haven't come together yet. So we need to make these modifications based upon the differences in the anatomy of the baby and very young child, and the differences, as you see in the photo, of where you're going to be. They're not necessarily going to lay down at the age of that little one who looks like he's maybe 7, 8, maybe 9 months old. It's hard to tell these days because sizes vary so much, but he's not going to be interested in just laying on the table and saying, do me, like an adult would do. Okay, so you have to know the core intent of each technique, as well as the differences in anatomy, and that's what we learn in the class. Next slide. Okay, so now we're going to start talking about things that occur. That was all day one. Day two of the virtual class, adaptations of the child treatment. So this is where you go into learning in depth different variations of your hand positions when, for example, you're doing a frontal release. It's releasing anterior. If I'm sitting up, that's different thinking about that than it is if I'm laying down, right? So positions of the therapist, positions of the child will vary, and we'll go over all of that in the class. How many grams of pressure, the rate, from a small to an older child. We discuss all of that. And the importance and adaptations for mouth work. Obviously, if you're working on a 3-month-old and they're either taking a bottle or breastfeeding, can you really get back on a Palpating? No. So we're going to talk about the adaptations that we have to do for really small people and small mouths. And remember also our key point that safety is first and foremost. So we'll pull together all the things that you learn when we go into these kinds of adaptations, and we keep coming back to it over and over again. Variations in hand position, we've already discussed that. You've got to know those core intents. What direction for the release?
Okay. I guess it wanted to repeat.
I guess that was important.
And then review of previously learned modifications.
Exactly. So we can go on to the next slide. We're going to be talking, this is a topic, at least in the States, that's, and Carol, you might be able to speak more to that in Europe, but this is a topic in the States that is really important right now. I'm not sure that we know. In fact, I'm pretty sure that there is no exact knowing of why we're seeing more of it these days. But this is what it looks like. It's tongue tie. And this is what it looks like when you see a true tongue tie. See how anterior that frenulum is and how it pulls on the tongue and makes a heart shape. Now, there are evaluations. I think the world standard has 9 different parameters. So it's not just this that you're looking at, but there's going to, Carol and I and Kathy have just yesterday been brainstorming, and we're going to do a class, and I think Tammy will show you the dates at the end of our presentation, but we're going to be doing a 1-day class on this topic, about 3 hours virtually, so that you can learn more about the issue and have a greater understanding of it from a craniosacral perspective. But we're also going to be doing, for those of you who have had PEDS 1 and who have had the CCPB classes, or at least one of them, we'll be doing a 2-day class where we'll go into far more depth And I think you'll find it very exciting. And for those of you that are seeing a lot of this in babies, or project yourselves into the possibility of this, it's a very, very exciting and important thing to do. So again, Tammy will give you the dates and the times for that at the end of this presentation. Next slide. So we learn in PEDS 1 that it's not just about the child that's on the table. And it never is when you're working with children. Any of you who've had experience teaching in the schools, for example, know that the family is extremely important in terms of the child's function at school. So the same with craniosacral therapy. We need to blend, we need to meld, not only with that little person, but with everyone who's in the room, that whole family dynamic. And you'll learn in this class exactly how to do that, because think about it, the family is the soup that the child swims in all day, every day. If you're treating them, you may only get to see them 1 hour a week. You can make a big impact, but you need to impact the whole dynamic. And remember that family might have goals for the child, but it's really the child's body that we're listening to in order for that child to meet whatever goals its innate wisdom wants to meet at that particular time. Next slide. So these are some things that have been added in the updated PEDS 1 study guide, as well as the tongue and lip tie. This is coming from a perspective of conscious parenting. And I find that, having been a pediatric specialist for close to 35 years now, I spend a great deal of time. I don't know whether it's the days, the era that we live in, with so much technology and parents who are both working. But it seems to me, and you all might have your own opinion from wherever you're listening, seems to me that there's more anxiety in the world right now. That could very likely be from the COVID pandemic in part, but I think there's a lot of other factors. And I think it's important that we model for the parents who are in the room with the children that we treat exactly how to talk with that specific child based upon how they're presenting. So, for example, a real slow moving, happy-go-lucky, noticer of everything kind of life child comes in the room. Watch them as you say words like, "I'll wait for you. Take your time. You know, seeing you really makes my day." These are words of encouragement. And if the parents hear us say it, they'll repeat them. And that's very important in these times. Confidence building words for that child who, and you might be able, I can certainly relate as an adult to the planner, always planning, you know, and pursuing, and I want to do this and I want to do that and I want to fulfill my dreams. Watch them and observe their facial expressions, their body, their cranial rhythm as you say things like, you know, mistakes are just learning. You don't have to be perfect. Okay, take a few more minutes to get your project done. That's okay. It makes a difference. It makes a huge difference. Think about how it would feel to you if somebody said those words, okay? There are affirming and connective words for the hard-working yet oftentimes unappreciated child. Maybe that's that middle child. Watch the tension go away as you say things like, I really appreciate you. I'm listening. You know, you really matter. And the last is the healing and hope-filled words. For one of those children that seems to be so oriented to perfection seeking, they tend to go over and over and perseverate on their past mistakes. But I didn't do good on that math test last week, and I just know that I can't do math. And watch them, watch their body, their facial features as you say words like, you know, I really love you. I had a little girl yesterday. She has a genetic disorder and she's 9, but she functions at about more like second grade. Um, and I'm working on her head. She's got a severe scoliosis and low tone. And all of a sudden she stops what she's doing and she looks up at me and she goes, do you love me? What do you think I said? Yes. Okay. So it's important that we perceive the stress levels of everybody that's in the room. That's critical when you're working on children. And you have the ability to limit some of that stress, and you learn all about how to do that in this class. And remember that it's so important, as I said in the beginning, to keep it playful. That's why you saw this guy, okay? Dr. John would always say, laughter is the best medicine. And one of the phrases that Carol and I love is that he would say, keep them laughing. This is a little guy, obviously, with severe neurological challenges, and yet we're able to do the work, and what's he doing? Laughing. You'll learn all about how to do this kind of thing. Let's talk now about, I think, SER is literally the gem that Dr. Upledger introduced to cranial osteopathy as a result of his work at Michigan State and then going forward. Most osteopaths, at least in this country, from the Cranial Academy, it'd be like the house cleaning woman that says, I don't do windows. They don't do emotions. So SER is very profound. I remember Dr. Upledger saying that when you get into a layer of tissue that you're releasing and it's held with a strong thought or memory, aka an energy cyst, that releasing that will have 5 times more impact on that person as a whole person than simply a structural restriction. So we'll go over how to do somatoemotional release with children, whether they can talk or not talk, and how we validate their individual experiences. Next slide. So I want to take time to talk about this one, very near and dear to my heart. I alluded to it at the very beginning of the slide presentation when I said stressed systems don't strengthen. Now, is a child who had a traumatic birth or a traumatic hospital experience after birth, or some trauma going on in their family, if they cry, that's their communication. They may not, have you ever been so upset that you couldn't talk? That's the way it feels for a child that's nonverbal. So yes, you're going to use your significance detectors. Yes, you're going to use your release signs. You're going to learn how to identify energy cysts. You're going to learn all of that from PEDS 1. And you're going to keep in mind tuning in to their reticular formation so that you know whether they're so stressed out that's not going to strengthen, whether they need a break, whatever it is that they need, you'll be able to provide. All right. So remember that crying is their story. And Carol, I'm sure, experiences this a lot when she's teaching her CCPB classes, in that lots of times, and perhaps some of you are mothers and you can remember, what did you do when your baby cried? It's okay, it's okay. Okay, I have parents with that all the time. Sometimes they never get to tell their story because everybody's trying to calm them down. It's okay, it's okay. They're trying to fix it without getting to the place of letting them tell it. So you'll learn the fine dance of how to do that in this class. Next slide. So, in order to prepare yourself to be the best possible therapist that you can be with children and babies 3 months and older, you need to do a lot of work on yourself. You've probably heard this in every single class you've had. Get treated. If you want to be a good therapist, get treated, get treated, get treatment, get treatment. Work on yourself. And in this class, we cover, once again, I know you've already done it in SomatoEmotional release, for those of you that have gone that far in your studies, completion of the biological process. But this is very specific in order for you to clear whatever is still there. Because when you start working on a baby or a child, if you haven't cleared your own issues about whatever their issue is, it's almost like a tuning fork. Do you ever do that? Strike the tuning fork and the strings on the piano will vibrate. Okay, that's what it's like. If you haven't cleared, they can't possibly clear. So we do this work, and on day 2, in order to do that. Now, with the virtual class, you'll learn about it. You'll be talked through some things, but obviously you can't practice that until you come together. But you'll learn all about what we have to say about that. Next slide. So let's jump now to last day, day 3, and we're going to cover the neurology behind behavior. Now, when I put this together in 2005, Dr. Upledger was still alive and very much like the triune brain model. So we've left that in there to honor him. You'll see how he described the neurology behind certain behaviors. And then we talk about another model, and that's reflex integration. Some of you have probably heard about that. Maybe some of you have practiced it. Maybe some of you have received it, or maybe you have a child who's received it. That's important to understand too. And the last piece is sensory integration, sensory processing. And that's another way of looking at why do you get the behaviors that you do from a neurological perspective. So I have specialty certification in sensory integration for 34 years, I think. So I know a lot about this one, but I didn't overemphasize it because it is another way of looking at it. Next slide, Carol. So we'll also cover in this brain, and this is new, updated for the PEDS 1 main study guide, so it's in your virtual as well. We'll take a look at that triune brain, looking at it specifically where your hands are. You can tune into that. If you know, that's what made Dr. Upledger so good, by the way, is that he knew exactly what was underneath his hands. He was had a fellowship in biochemistry as well as being an osteopath. So the more he knew, about the physiology and anatomy of what was under his hands, the better and the more potent the treatment could be. So we'll take a look at it from this perspective, and we'll apply that with our hands. Next slide. So again, sensory integration, and this is specifically for craniosacral therapists. Now, this slide that you're seeing is an actual class that I developed not long after I revised PEDS 1. This one is important because, again, it's a perspective of looking at why you see behaviors not only in children and babies over 3 months, but also in adults. So we'll talk a little bit more about that in the class. You'll begin to understand the neurology from this perspective. Next slide, Carol.
And that's just another view.
Yeah, again, sensory integration. It's the child's ability to feel, understand, and organize all the sensory information that comes from not only the environment, but from their own body, our own body. So it's received through all these sensory systems, and it is a way of, again, getting our hands on specific places to be able to help, but it's a way of understanding why they're coming in. I had last night, it was up late, writing a recommendation report for a 9-year-old who's coming in for therapy tonight and having their teachers meeting. In this country, we call it an individualized education plan. And so it was my recommendations based upon my observations with sensory integration of what I was seeing and why that was making learning so challenging for him. So I'm very happy to share all of this information with you, as is Carol. She teaches this class too. So again, we talked about covering primitive reflexes as a way of understanding behavior. You learn, what are they? What happens if it doesn't go away, if it doesn't integrate? And you'll also learn the causes of them not going away. We call those retained primitive reflexes. Some of you may know a lot about this, but we definitely will look at it from our perspective as craniosacral therapists, where we have our hands and what we can do in our treatment rooms to help. Next slide. So we explore at the end of day 3 some of the common problems that you'll see when you're working with the pediatric population. And again, always, always, always coming from a craniosacral therapy perspective. Some of you may be pediatric specialists from psychology or from some other field, but we're going to be always focusing on these diagnoses from a craniosacral perspective. What's it look like? How does it present? What happens in that particular situation? Torticollis and plagiocephaly. Torticollis is the twist, and it's a 3-dimensional twist, not just with the neck, but all the way down through the sacrum, and comes with developing later on untreated. Some of you may have seen it. Maybe you've got a family member or a child in the neighborhood that you know with it. It's a misshapen head. So plagiocephaly makes the head look like it's a parallelogram. Carol, can you grab your skull again real quick? So hold it so that we can see it from the top. Now,
The baby skull or the 5-year-old?
The 5-year-old's fine. So rotate it now slightly, about 45 degrees. And that's the way, too much, back just a little. There you go. Oh, that's the way it looks. So you could see how the occiput on the right side could become flattened by the pull of the twist of the membranes from the inside. So when we have this 2-day class on virtual class on tongue and lip tie, thank you, Carol. We're going to be talking about this because this oftentimes goes along with what is known in the medical model as posterior tongue tie. Remember, we showed you the slide. It's very anterior when it's a true tongue tie. So we'll get into some of this. We do it in this class briefly, but the other 2-day class will give you much more information on that and how to treat it. We cover learning disabilities. Some people include attention deficit disorder. That's what the ADD stands for. And attention deficit with hyperactivity disorder. Nowadays, at least in the States, ADD comes under the heading of ADHD. It has a qualifier, and that qualifier is ADHD without hyperactivity. That's now ADD. We discuss seizures, how they look, how they present, what to be aware of. We go over cerebral palsy. We talk about all kinds of structural issues, immune issues. With the structural issues, I would also add that we talk about treating genetic disorders. And when I think of a structural issue, I can think of arthrogryposis, which is a contracture of all the joints, develops in utero. So we cover quite a bit, and it's important to talk about all those things because if you're not a pediatric specialist, you may not know. So we cover it all, and I find that very important and very helpful for people that are not used to treating the pediatric population.